My name is Richard Hurt. I'm Professor of Medicine at Mayo Clinic and Director of the Nicotine Dependence Center, but also chair of the leadership team for Global Bridges. And if you want to know more about Global Bridges, go to the website, globalbridges.org. So let us begin by having financial disclosure. First of all, I have no consulting agreements, but I do have a medical education grant from Pfizer Medical Education, but I have not, nor will I ever accept any money from the tobacco companies, because that's a serious conflict of interest. Let's start out with a case. And the case is a 52-year-old married man with back pain, and it's a fairly typical patient that we've seen at the Nicotine Dependence Center over the years. He's been a smoker since age 14, smoking 40 cigarettes a day. Began cutting down a bit, down to 20 to 30 cigarettes per day. His wife is an ex-smoker, but she's very supportive of him. He smokes his first cigarette within 5 minutes of arising in the morning, which indicates a high level of dependence. And he's had one period of smoking abstinence for about a month of using a single-dose nicotine patch, but during that time he had pretty severe nicotine withdrawal and relapsed back to smoking. Nicotine gum, bupropion have not been helpful to him, nor has varenicline been helpful. So when faced with a patient like this, realizing that we need to we're focusing on pharmacotherapy, not behavioral treatment, what will we do? Ask him to use bupropion and nicotine gum, a single-dose 21 milligram patch plus the nicotine inhaler, 2 21 milligram nicotine patches plus nicotine inhaler, or varenicline. Now, we'll come back to this case at the very end, and we'll go through the answers and let you know exactly what happened to this particular patient. So in 2009, we published an article in CA, which is the American Cancer Society Journal, about best practices. And we used the U.S. Public Health Service guideline. Now, recognize in other parts of the world you'll have guidelines in your own country, which will be more specific for your country, and you should use those. But this is the guideline we use. We also endorse the use of behavioral treatment, which is a key part of our treatment. We also recognize addictions treatment and the fact that nicotine dependence is a severe addiction. Pharmacotherapy is what we're going to talk about today. And then the thing that we really need to learn more about is relapse prevention. You also need to understand the neurobiology of tobacco dependence, because the patient who's having a really difficult time stopping smoking needs to be able to understand that they're different. They've been affected by this differently, and I'll show you some slides about the neurobiology. We use a medical encounter as a teachable moment, and the more severe the medical encounter, the more teachable the moment. For example, if a person enters the hospital as a smoker and has a heart attack, then the chances of that person stopping smoking is probably over 55 or 60%. Telephone quit lines and internet sites are helpful. One internet site in particular that we've helped develop is becomeanx.org. That's the American Legacy Foundation website, which is free, and you can see all kinds of different things on that website for your patients. And we also know that public policies are important, and Global Bridges is into treating tobacco dependence and training others to do that, but also creating advocacy groups through healthcare professionals to help with taxes, smoke-free workplaces, and other policy changes. Now, to understand this, we need to understand the product, and the product is the cigarette. The cigarette is a complex mixture of over 7,000 chemicals with over 60 known carcinogens. We call it the holy grail of drug delivery devices because it's aimed to get nicotine to the brain as quickly as possible. It is the most efficient delivery form for nicotine that exists. It gets it to the brain faster than using it intravenously. And the cigarette manufacturers have continued to modify their product over the years to make nicotine go to the brain so quickly. And actually the secret of the Marlboro was not the theme from the Magnificent Seven or the Cowboys or anything like that. The secret of the Marlboro was adding ammonia to the tobacco to freebase the nicotine. They were freebasing nicotine before the drug culture knew how to freebase cocaine. These high doses of nicotine, which are delivered by cigarettes, cause upregulation of the nicotinic acetylcholine receptors, and this is the neurobiological basis for why it is so difficult for some people to stop smoking. All people are different, and so there are genetic factors that influence tobacco dependence, and that is really the difference between the person who experiments with smoking, never becomes a smoker, compared to a person like me who became addicted almost immediately after starting smoking. The bottom line is that left untreated, cigarettes will kill 60% of the smokers if we don't intervene and help them to stop smoking. Here's an example of these high arterial concentrations of tobacco, of nicotine produced by cigarettes. It's on the left panel as you face it. On the right panel is the same schematic for crack cocaine. So inhaling crack cocaine delivers the cocaine, the same chemical, much more quickly, and therefore crack cocaine is more addicting than snorting cocaine. So, and thus cigarette smoke and delivering nicotine to the lungs is more addicting than any other form. When it reaches the brain, it causes upregulation of the nicotinic acetylcholine receptors. The top panel shows a non-smoker. These are autopsy studies and shows the stain for the nicotinic acetylcholine receptor in a non-smoker compared to that of a smoker. The lower panel shows the smoker has billions more of these receptors, and therefore this is the neurobiological basis for why smokers who are addicted have so much trouble stopping smoking. These receptors will downregulate probably in about 6 to 12 weeks after a person stops smoking, but they have memory to what this is all about, and therefore the cravings can go on for months or even longer, and those are very powerful urges to smoke that eventually fade, but they're based in these receptors that have been changed and altered by smoking over time. Now, just to show you how potent the cigarette is, the top panels are the control PET MRIs. The bottom panels are the cigarette smoking conditions. And the more blue it is, the more saturated the nicotinic receptors are. So with one puff of a cigarette, it doesn't do very much. 3 puffs of the cigarette, which is the middle of the lower group, shows some blue. 1 whole cigarette, more blue, and 3 whole cigarettes produces almost 80% saturation of the receptors. So again, the cigarette is the most efficient delivery form for nicotine that exists, and the manufacturers continue to tweak it in order to make it even more efficient. So let's talk about pharmacotherapy a second, and we're going to bring together the evidence, but also the art of medicine, and you have to use your usual clinical decision-making skills and knowledge of pharmacotherapy to really figure out what the best dose for the patient and the best medication for the patient is. The patient's involvement is very keen because they've had past experience with stopping smoking, and many of them have used medications, and you can use that past experience to help build the best and most efficient pharmacotherapy for that patient. And patient preference is important also, because patient preference, if a person prefers one over another, then they're much more likely to comply and adhere to the medication regimen. The way we use this, we use the longer-acting medications, which are the nicotine patch, varenicline, and or bupropion as our base or floor medications, and then use short-acting NRT for withdrawal symptom control. And combination pharmacotherapy is the rule, not the exception. So let's start out with the basic concepts. The basic concepts, we need to treat tobacco dependence for the serious medical problem that it is. Again, left untreated, tobacco dependence will kill 60% of the smokers. Motivational counseling is very important, and that plus pharmacotherapy are the things that we do that are evidence-based and can help people to stop smoking. There is a dose response to counseling, so the more you do, the more often you do it, the more intensive it is, the better the outcome. Higher nicotine patch doses are better than lower doses. Combinations are better than monotherapy, and longer treatment is better than shorter treatment. This is not a strep throat, nor is it a urinary tract infection, and so we can't treat it like an infectious disease. Rather, it's a chronic, relapsing, remitting condition that needs longer-term treatment. So in the U.S. Public Health Service guideline, there are 7 medications which are declared to be first line, and we'll review each one of those. Combination pharmacotherapy is mentioned in the latest edition of the practice guideline, and the 2 second-line drugs, clonidine and nortriptyline, I won't talk much about at all, except to say that the last time I wrote a prescription for clonidine was many years ago. Nortriptyline is very useful. There's good evidence that it works, and for people who may be allergic to varenicline and bupropion, nortriptyline might be a good alternative. So how do we do this? Well, we take the long-acting one, pick 1 or 2 from here, the nicotine patch, bupropion, and or varenicline, and then combine that with the short-acting NRT for symptom control. Pick one or two from here: nicotine gum, nicotine inhaler, nicotine lozenge, and/or nicotine nasal spray. So that's the basic concept of how we treat tobacco dependence at our institution. Now, the nicotine patch has been shown to be effective in placebo-controlled trials. There's a growing literature of a dose response, though it's not a linear dose response. With a single-dose patch, you get about a 50% median replacement if you base that on serum cotinine concentrations. And most people who do not completely stop will reduce their smoking while using the nicotine patch, but that usually indicates that they're being undertreated and they need a higher dose. The time to peak serum concentration varies by different patches, but it ranges from about 4 to 8 hours, but you need to check the patch itself, and you can gauge then how good their symptom relief is depending upon how long it takes to get to peak serum concentration. Now, this is an early study we did which shows in the middle, the yellow line shows the serum cotinine concentration on average of all the smokers that were admitted to this special study. At baseline, when they were entered, they had a serum cotinine concentration of around 260, and at steady state on a single-dose nicotine patch, it was less than 150. Therefore, that's kind of the median of 50%. The top line is one smoker. The bottom line, the pink line, is another smoker. So it shows that there's a large between-subject variability in these smokers. So all smokers are not alike. So we thought if you're underdosing with a single-dose nicotine patch, maybe we should do a higher dose. So in this study, the top line, the red line, is 2 standard dose patches per day, and the green line is placebo, and the other doses are in between. You can see at baseline, when they were in their free-living state as an outpatient, the baseline levels clustered around 230 or so. And at admission, they went up somewhat because they were smoking more in anticipation of stopping smoking. And then the people were randomly assigned in a double-blind placebo-controlled fashion to 2 patches, 1 patch, a small patch, or placebo. The red line at the top shows over 100% replacement for a large number of these subjects, but only one subject, who was a light smoker, smoking 10 cigarettes a day, showed signs of nicotine toxicity, nausea, and vomiting. We took the patches off, we re-challenged him, he developed the same symptoms again. We broke the code, and he was on the high-dose 2-patch condition. He was the only one of the light smokers that had that to happen. So the tolerance that people have to high levels of nicotine are quite extraordinary. And so we think that high-dose nicotine patch therapy is safe, certainly for heavier smokers. That's what we concluded. We also can use the smoking rate or the blood cotinine to estimate what the initial patch dose should be, and assess the adequacy of nicotine replacement by talking to the patient. They can tell you how well they're doing as far as urge control or withdrawal symptom relief, or you can redraw the blood cotinine concentration and calculate a percentage replacement. The more complete the replacement, the better withdrawal symptom relief, and the higher percentage replacements may increase efficacy, but it's not a linear response. Doubling the dose does not double the efficacy. It's less than linear. So this is the way we do this based on cigarettes per day. For the lighter smokers, the lower patch dose. The heavier smokers get 21 to 42 milligrams per day, and the heavier smokers, more than 40 cigarettes a day, get 42 plus milligrams per day. The most nicotine patch dose I've ever used in a single patient is 3 21 milligram patches plus a 14 milligram patch plus bupropion plus 2 short-acting NRT, and that's what was required to get her withdrawal symptoms under control. Now, I've already said that longer is better. This is one of the studies that shows that, 24 weeks versus 8 weeks. There's similar smoking abstinence at the end of the first period, and at week 24, the point prevalent smoking cessation rate was 32% for those on the longer therapy versus 20%, an odds ratio of 1.81. At 52 weeks, the prolonged smoking abstinence with extended patch therapy was still significantly higher. And it also delayed relapse to smoking, which we know is predictive of future attempts and success with future attempts. This is just the graph showing what I just said. At the end of the 8 weeks, the rates were very similar. Then the extended treatment group had a better outcome at week 24 and at week 52. These are the current nicotine gum and lozenges that come in 2 and 4 milligram sizes, and as I mentioned, we use them for the short-acting NRT for withdrawal symptom control, and they can use them on an ad-lib basis. The nicotine nasal spray is the same nasal spray that was introduced many years ago. It hasn't been changed. It's a pretty difficult product to use, but it does give good withdrawal symptom relief. This person has her head tilted back a little bit far. It should be more neutral, and the squirt of nicotine goes into the nose. 1 squirt in each nostril is equal to 1 dose. The nicotine inhaler is a misnamed product. It really is not an inhaler. It does not get nicotine into the lungs. The cotton pledget in the middle of these cartridges has liquid nicotine, and when you puff on it, you puff really hard to draw air over the nicotine, which vaporizes the nicotine, and it's delivered to the lining of the mouth, so it does not go into the lungs. The only thing that does that to date is the cigarette or pipe tobacco or cigars if you inhale the smoke. Bupropion is the other long-acting drug we'll focus a little attention on now. It's a monocyclic antidepressant. It's been around for at least 2 decades. It inhibits the reuptake of both norepinephrine and dopamine, but it also has a direct inhibitory effect on the nicotinic acetylcholine receptor. And basically, we do not know which of these is more important in helping people to stop smoking, but it clearly works. It also may attenuate the weight gain that abstinent smokers sometimes have, and you have to take it for a prolonged period of time for that to happen, but this is the only one of the drugs we're going to talk about today that does that. Now, the first study that was published was in the New England Journal in 1997. This was a dose-response study showing a dose response for the 300 milligrams dose per day compared to placebo or the other 2 doses. That was true the week 7 of the study, which was the treatment part, and at 6 months and at week 52, there was still efficacy for both the higher dose and the 150 milligrams per day. The one thing we did not expect to see was the attenuation of weight gain. So here we are. On the top bar are the people assigned to placebo. On the bottom are the people assigned to the 300 milligram day dose, and those people had much less weight gain compared to the other 3 groups. Once they stopped the medication at day 42 out here, though, however, the weight gain came back in the people that had been abstinent from start, and they gained the weight back so that it was not different. So 6 or 7 weeks of treatment with bupropion is not enough to attenuate the weight gain. We did a prolonged study of using bupropion for relapse prevention. So over here, the subjects all got open label bupropion. Then if they were absent from smoking here, they were assigned to bupropion 300 milligrams a day for the rest of the year, or to placebo, and then they were followed up for another year. So the results showed that almost 60% were abstinent at the end of the open label phase. The relapse rate was lower in the active group for the short term, but not for the long term. The median time to relapse was much longer in the active group compared to placebo, and again, this is predictive of a future attempt to stop smoking. Those that have had more prolonged abstinence are going to do better with a future attempt. The absolute smoking abstinence rate was higher in those on the longer term, but it was not a doubling. We'd hoped to see a doubling of this, but this was different, but it was not a high rate of difference. The weight gain, however, was different. There was more weight gain in the people on placebo compared to the active group, so prolonged treatment with bupropion up to a year may very well attenuate the weight gain that is seen often in smokers. So in summary, there's a dose response in efficacy in treating smokers. We rarely go beyond 300 milligrams a day. Our psychiatric friends sometimes will use more for treating depression, but we rarely do that. It seems to attenuate the weight gain if you use it long enough. In other studies, which I didn't show you, it's more effective than the nicotine patch. It does seem to delay relapse to smoking if you use it for a prolonged period of time. And it's been studied in a wide variety of different populations: recovering alcoholics, people with COPD, people with coronary artery disease, and so it's been shown to have a comparable outcome in each of these groups. So we'll shift our attention now to varenicline. Varenicline is a partial agonist and antagonist, and it acts directly on the alpha-4 beta-2 nicotinic receptor. Its agonist action stimulates the receptor, therefore helps to reduce withdrawal. Its antagonist action blocks the receptor and therefore decreases the reinforcing effect of smoking. The problem is, I think, that at a 2 milligram dose, we do not have complete saturation of the system like you see with smoking a cigarette. That's why people will still have withdrawal symptoms even though they have a regular dose of varenicline. And so that's where some of the art of this comes in. If you have someone who's struggling, having a lot of withdrawal symptoms, and they're tolerating the medication, then sometimes we'll increase the dose of varenicline to 1 milligram in the morning, a half milligram in the midday, and 1 milligram in the evening, or even up to 3 milligrams, 1 milligram 3 times a day. This is a cartoon showing the effect on the receptors with varenicline producing an action potential which releases dopamine, and that gives you the pleasurable part of this. And then the antagonist effect blocking these receptors, but I don't think it blocks all of them. I think that there's a large number, particularly people with high levels of dependence who have a very upregulated system, then they're going to have partial response to the standard dose of varenicline. So I'm going to show you a couple of studies. This is one, the top bar is the varenicline group, the middle lines are the bupropion group, and the bottom line shows the placebo group. The odds ratio comparing varenicline to placebo at the end of treatment was an odds ratio of almost 4. An odds ratio comparing varenicline to bupropion, the odds ratio was almost 2. So varenicline in this study was highly effective, more effective than either placebo or bupropion, and the effects lasted out to week 52 with similar relapse rates in all the groups. Side effects, fairly common. Nausea is the most common side effect. It also causes abnormal dreams, vivid dreams are what they're called. Bupropion also has side effects, and these are adverse events that were reported by the subjects and not necessarily related to the medication. But the bottom line shows the importance of this is that people, even though they had fairly frequent side effects, were fairly compliant and did not discontinue because of adverse events in any of the groups. It was similar across the 3 groups. A more extended use of varenicline, similar to the bupropion study I showed you earlier, it's 12 weeks of varenicline open label. Those who stopped smoking were randomized to receive varenicline for another 12 weeks versus placebo. And the primary endpoint was here at week 24, but also what the rate of absence was at the end of 6 months in 1 year. So here we are, the graph showing the open label phase, showing varenicline to be highly effective in helping people to stop smoking. But then once assigned to active or placebo, the varenicline group on top maintains a higher level of abstinence compared to placebo at both week 24 and out here at week 52. We've all heard about the adverse warnings about varenicline, and this is the warning that came out of our Food and Drug Administration. And the psychiatric symptoms that have occurred, some of them also occur in people who stop smoking, such as depressed mood or change in mood, agitation are sometimes associated with stopping smoking. So sometimes it's difficult to separate out what could be drug effect versus the effect of withdrawal. When you stop smoking, everything changes, and mood is one of those things that does change. And we also know that people who are smokers have a higher rate of a past history of depression. They also have a higher rate of suicide. Nonetheless, we take this very seriously. We advise all patients and family members, if they observe some changes in behavior, then they should stop the medication and call us or report back to their physician as soon as they have these symptoms, so we can help try to sort this out. People with serious psychiatric comorbidity were not included in the original clinical trial, so that's another word of caution. There is a large trial that's getting underway to try to determine if there is an effect in people with psychiatric comorbidity, but it's going to be a couple or 3 years before that study is completed. There's been no cause and effect relationship that's been established to date, but this is an association and a precaution that we need to pay attention to. So in summary, this is the first alpha-4 beta-2 partial agonist antagonist. It has efficacy in initiating smoking abstinence and may improve long-term smoking abstinence if it's used longer. Nausea is a frequent but a mild side effect. And to date, and those are the operative words, to date, varenicline appears to be safe and effective. And as with any new drug, even though this drug's now been out for over almost 6 years, with any new drug we have to be very careful to not overlook any potential side effects that may be occurring. It is a first-line medication, and we use it in that way. One of the questions we had initially was, would there be a possibility of using varenicline in combination with bupropion, because they have different mechanisms of action, and that actually may be a fairly good combination. The next slide shows the pilot study that we did that was published in 2009, where everyone got open label, both varenicline and bupropion, small sample of only 38 smokers, fairly typical group of people as far as their age and their years of smoking and heaviness of smoking. They got 12 weeks of both varenicline and bupropion SR, and the smoking abstinence at the end of treatment was quite high, 71%, and at 6 months it was still almost 60%. So we think that there may be something here, and we're doing a randomized clinical trial right now to determine if this effect is real. Sleep disturbance was present, and that, as you know, goes along with bupropion, and nausea, which goes along with varenicline. Both of them were fairly frequent side effects, or at least adverse events reported. So I've already mentioned combinations, and there have been several combination studies, but this is one that's particularly interesting because it used triple pharmacotherapy, the nicotine patch versus the patch plus bupropion plus the nicotine inhaler. And what it showed was that people who were on the combination used it longer, as far as because they had a better outcome. The time to relapse was longer in the people on the triple therapy, and the adverse events was basically the same in both groups, and the smoking abstinence at six months was almost double compared to the patch condition. So it appears that triple pharmacotherapy in this study was effective. And then there was another one where there was short-acting versus long-acting versus combination, and this was an 8-week treatment. Compared to placebo, all of them were more effective than placebo. And at six months, the best combination was nicotine patch plus the lozenge, which produced an odds ratio of over 2, so it was twice as effective as placebo. This is just a graph showing what I just said. The top line is the nicotine patch plus the lozenge, and the others are fairly clustered, fairly close together, but the best combination, at least in this study, was the nicotine patch plus the lozenge. So to go back to where we started, treating tobacco dependence, you have to use your clinical decision-making skills, your knowledge of pharmacotherapy, your knowledge of the patient. The patient is important too, and they can express a preference, and their past experience is something you can learn from. We use the patch plus varenicline and or bupropion. There are our base medications, and then we add to that short-acting NRT for nicotine withdrawal symptom control, and combinations are the rule rather than the exception. We also have to remember that we're dealing with a severe problem for people that are addicted. The monkey on the back of this poor smoker shows his talons are into the poor guy's shoulders. He's enticing him to have another cigarette. So we have to treat this for the serious medical problem it is, and combination medications are a part of that, as well as behavioral counseling. So let's go back to our patient and then see what we have in the way of answers. So just to refresh your memory, he'd been smoking a long time, heavy smoker, 40 cigarettes per day, had cut down to 20 to 30 cigarettes per day. His wife was an ex-smoker, but very, very supportive. He smokes his first cigarette within 5 minutes, which is an indication of the severity of nicotine dependence. His longest period of smoking abstinence was about a month using a single-dose nicotine patch, but he had withdrawal symptoms during that time, which caused him to relapse to smoking. The other therapies, the gum, bupropion, did not relieve the cravings. Varenicline had little effect on him at all. And so, presented with that patient, what would we do? Well, would we put him on bupropion and the gum? They did not seem to help before. would give him a single-dose nicotine patch plus a nicotine inhaler. That might be okay, but remember, he's a pretty heavy smoker. Even though he's cut down, he was a 40 cigarette per day smoker to begin with. How about 2 patches plus an inhaler? So 2 21 milligram patches and using the nicotine inhaler for withdrawal symptom relief. Or varenicline didn't seem to help before, why would we think it would help this time? So the answer to the question is we started him on 2 21 milligram patches and the nicotine inhaler for ad lib use. And we had him call back in a couple of weeks. He had a good initial response with withdrawal relief and stopped smoking for about 10 days. So he was actually doing pretty well. But he noticed that late in the afternoon, early evening, his use of the inhaler would increase because he had pretty severe cravings in the late afternoon, evening. And these would sometimes just continue until he went to bed. He told me one time he went to bed because the cravings were so bad, went to bed, covered up his head with a pillow, and finally the cravings relented. He went to sleep, and that was the only way he could deal with that. So he's struggling. So what do you want to do next? Well, alternatives would be just to toughen it up and tough it out and pull up your socks and go on. Be worried about the inhaler use because he's using it more in the afternoon and the early evening. Add another short-acting NRT for his ad lib use, or add a 14 milligram nicotine patch in the late afternoon. Now here's where the art of it comes in, because there's no randomized clinical trial that's going to tell you what this answer is. So you have to talk to the patient. The patient actually has told you what you should do, and he is really pretty good at this. So what do? Well, we added a 14 milligram patch at 4 o'clock. Remember, the time to peak concentration will be 4 to 8 hours, so adding that 4 o'clock in the afternoon, his evening cravings almost completely resolved. He noticed he didn't have to use the inhaler as often. So we told him to continue on the 2 21 milligram patches in the morning plus a 14 milligram patch in the afternoon and use the inhaler and let us know how he's doing. And he continued with that, phoned back in 2 weeks to follow up. So how do we know how long to use these medications? We don't. We have to individualize that for each individual patient. So what we tell the patients is you need to be able to get through almost every situation where you would have the urge to smoke or a relapse situation and get through them comfortably before we start reducing any of the medications. And in this case, what we recommended to him was once he got through that, then he could reduce the morning dose of the nicotine patch from 42 milligrams a day to 35 milligrams a day, and do that for a few weeks before going to a lower dose. So I'm going to do one more case, and then we'll have time for questions. This is another patient we saw, a 66-year-old wooded woman. She had COPD, and she'd had an aortic valve replacement. She smokes 20 to 20-plus cigarettes a day, and at the time we saw her, she had a carbon monoxide level of 43 parts per million. She had stopped smoking one time for about 2 years, but she always had withdrawal symptoms when she would try to stop since that time. She'd been using nicotine gum in the past few weeks to decrease her smoking rate, and that helped a little bit. She lives alone. All of her friends are smokers, so she's really in a kind of a difficult situation without much support. And she comes in saying, I would like to use varenicline, patient preference. So what are we going to do? Talk her into using the nicotine patch, use the 21 milligram patch plus a 14 milligram patch, use bupropion plus nicotine gum, or just start on varenicline. And again, patient preference is an important part of this, and so we'd be kind of foolish to try to steer her in a different direction unless there was some reason, some serious adverse event reason that we would do that. So she started varenicline, and she would have withdrawal symptoms during the run-up to her stop date, and she continued using nicotine gum. She'd been using 10 to 12 pieces of nicotine gum per day to control the withdrawal symptoms, and once she started on varenicline, there was more nausea as the varenicline dose was increased. And so she decreased the nicotine gum, and the nausea got better. Most of the time when nicotine gum causes nausea, it's because they're chewing the gum like gum and swallowing the saliva, and the nicotine in the GI tract causes nausea. Now, she had not stopped completely, but after the first 2 weeks, she had reduced down to now 5 cigarettes per day, and her withdrawal symptoms were less. So this is a telephone follow-up at 2 weeks. So what are we going to do next? She's not stopped completely, so she's at risk to relapsing all the way back to her previous level of smoking. Should we give up and start her on nicotine patch therapy? Should we increase the dose of varenicline? Should we add bupropion to the mixture? Should we continue the varenicline and provide support through the telephone counseling or an office visit? Now again, here's where the art of it comes in, and dealing with this particular patient, this is what we did. We said stay with the varenicline. Unlike nicotine patch therapy, which shows that if you have not stopped smoking in the first 2 weeks, you're not going to stop smoking. With varenicline, the effectiveness continues to go on for the first several weeks. So staying with the varenicline might be a good alternative, and she needed good support and encouragement from her healthcare professional in order to stay with this. Now, another answer that could have been used would be to increase the dose of varenicline, and that would be nothing wrong with that. You could take a milligram in the morning, a half milligram at noon, and a milligram in the evening to see if that would help her to stop using those few cigarettes she was continuing to use. So there probably were 2 good answers to that question. Again, you have to know the patient, have to understand the patient, and deal with the particular patient's needs as a healthcare professional. So we are now toward the end, and we can take questions.
Hi, my name is Ina Parvanova, and I'm the Communications Director for Global Bridges. I wanted to thank you for participating in the webinar and to encourage you to type your questions. We have close to 100 participants, so we can't unmute you, but we encourage you to type your questions, and Dr. Hurt will read them out loud and respond to as many as we can. And one other point, we will make available Dr. Hurt's presentation and the audio from today's webinar, and you will be receiving an email tomorrow with the link to the presentation.
Okay, so the first question has to do with reduced to quit and how we can reconcile what I said about the first 2 weeks of nicotine patch therapy with the reduced to quit. The earlier literature with nicotine patch therapy showed that in analyzing all the factors that went into predicting success, that if they had not stopped smoking completely within the first 2 weeks, the chances of them stopping smoking completely at the end of treatment or at the end of 1 year was close to 0. The reduced to quit is philosophically different than those studies were, and we know that the reduced to quit seems to have efficacy, and for some people that really is a good way to do this. So I don't think there's any real conflict there, except that one was focused on smoking abstinence at the target quit date, and the other is focused on reduced to quit. Totally different study designs. With the second question is, did the gentleman with patches take them off at night? No. We usually will leave them on unless they have vivid dreams enough to disturb their sleep. And so remember, the time to peak concentration for the nicotine patch is 4 to 8 hours. So by the time you get to bedtime, the amount of nicotine being delivered is relatively small compared to earlier in the day. And unless it's causing vivid dreams to the point that it's disturbing their sleep, then we keep them on 24 hours. The question sometimes about insomnia versus vivid dreams was resolved many years ago in a sleep study. And in the sleep study, they were randomly assigned to active patch or placebo, and the smokers who had the best sleep quality by polysomnogram were the smokers who stopped smoking and were using the active patch. The people who had the worst sleep were the people who had stopped smoking and were assigned the placebo patch. So insomnia is a withdrawal symptom. Vivid dreams is probably an effect from both varenicline and nicotine patches. How long can we go with the dose of NRT? When I'm asked the question, how long do I need to use this medication for any of them, is as long as it takes. And for some people that may be many months, and for some people maybe even longer than that. Probably the longest time we've had that I've had an individual patient on, a patient with Berger's disease, and he was on high-dose nicotine patch therapy plus bupropion initially and continued on that for about 6 months. We reduced his patch dose, and he was off the patch within another 3 months, but he stayed on bupropion for over 2 years. So the next question had to do that the longer one remains to quit before relapsing, the better the chance that they will re-quit. I can't cite you the exact citation for that. There have been at least a couple of studies that have shown that the time to relapse in a previous attempt to stop was predictive. The longer the time to relapse was predictive of a success rate. I think that one of the studies may have been from Sharon Hall at UCSF, but I don't have it on the tip of my tongue. Okay, we work primarily with mental health and substance use disorder providers and are often asked about Chantix. Their inclination is not to use it at all. Any advice? I think that people who have substance abuse or other mental health disorders you can use varenicline in them. I think that with any medication they need to have good follow-up regardless of what their mental health status is. We've used varenicline clinically in the wide range of people with substance dependence, recovering or not recovering, as well as in people with various mental health disorders, including schizophrenia and depression being treated. So I don't think there's any contraindication. When you think about these drugs, you need to think about their mechanism of action, and varenicline has its main action on the alpha-4 beta-2 receptor, which is fairly specific. And so I don't have any disinclination to use these medications in those patient populations. The question about cost, how much does pharmacotherapy cost on the average? Bupropion is probably the cheapest is nortriptyline because it's generic. I can't tell you exactly how much it costs. Varenicline probably is about 120 milligrams, $120 per month. It's not generic, obviously. Bupropion is less than that because it is generic. The patches cost about $2.50 a day or for a single dose patch. So these things are not inexpensive, and sometimes insurance covers them and sometimes it does not. What about vaccines? Well, the only study that's been reported was the Nabi vaccine, and there was no difference in active versus placebo. When they tried to analyze based on antibody titers, it does seem that the people with higher antibody titers may have had some effect. So we're looking to the next generation of vaccines to maybe be better and have a better antibody response. But that's yet to be proven. So right now the vaccines have not been proven to be effective. With the second patient, the one that we said to stay with varenicline, would you consider adding bupropion if she was still smoking after several weeks? I actually would. I think that the combination of varenicline and bupropion is a good combination, though it has not been proven to be effective in a large randomized clinical trial. The levels of efficacy we saw in our pilot were such that we have used it clinically in patients, particularly patients who have had a previous good experience with bupropion, and they come in and say, well, I'm really having trouble with just bupropion by itself. can you think of another way to do this, and adding varenicline to that scenario would be okay, and vice versa for the patient that we just talked about. Okay, please comment on the suicidal effects of varenicline. The mental health and mood changes and suicidal ideation that have been associated with varenicline, I cannot think of a biologically plausible reason why there would be a cause and effect. And though it's an association, the cause and effect relationship has not been proven. So I don't know that we can say anything more than that there's an association, and we should warn patients that this has been reported, and that if it occurs in the patient, then the person should stop smoking, stop using the medication, and call us to let us know what symptoms they're having. Again, smokers are much more prone to have had a past history of depression, and smokers also have a higher rate of suicide. And you have to remember, suicide is a relatively uncommon phenomenon, and it's not always associated with depression. In fact, sometimes it's just more impulsivity than it is being associated with some other mental health disorder. So the next question is there a time limit to the medications? This person works in an open group of counseling plus medication, and some patients receive nicotine replacement therapy alone or plus bupropion for up to a year, and they finally succeed to achieve abstinence. Is this okay? Yes, it is. As I mentioned earlier, when I'm asked the question, regardless of which medication or combination we're talking about, when I'm asked the question, how long do I need to take this medication, the answer is as long as it takes. How often have you used varenicline in patients with schizophrenia, and how often did you encounter psychotic worsening? We only have a handful of patients that we've treated with varenicline who are stable schizophrenics, and we've had no psychotic breaks, but we're talking about just a handful, just a very small number of patients. Within the chronic mental illness subpopulation, is there evidence that quitting worsens a patient's mental illness? No. If the person has, let's just take a schizophrenic patient, for example, they're often on psychotropes that can cause pretty serious side effects at the doses that they have to take. And one of the reasons they have to take such high doses is that tobacco smoke induces the hepatic enzymes and causes the drugs to be metabolized more quickly. And so when a schizophrenic stops smoking, oftentimes we can reduce their dose of their psychotropic medications, which means that they have fewer side effects from that. So in many respects they improve, but treating schizophrenic smokers is really difficult. They're heavy smokers, they're highly dependent, and you have to really spend a lot of effort in order to help them stop smoking. And so we treat them very aggressively and engage them in the treatment process, have them come back for frequent visits with fairly intensive counseling as well as fairly intensive medication therapy. Where can I find additional information on medication combinations as well as simultaneously using more than one patch? If you go to the article that I showed you early on in CA, which is the American Cancer Society article, it was published in 2009, and that basically has all of what I've just said in this webinar in there, as well as other treatment modalities like behavioral counseling, engaging the healthcare community in treatment. And also it talks about our program here, where we have tobacco treatment specialists who deliver the services under the supervision of a physician, and we have services that are face-to-face bedside counseling in the hospital, and we also have a residential treatment program where patients are admitted to a special residential unit for 8 days of very intensive treatment and very intensive pharmacotherapy. And that article, the article in CA, would answer those questions. How many patches can be prescribed in a day? It depends on the individual. As I mentioned earlier, the most I've ever used in one patient is 3 21 milligram patches plus a 14 milligram patch plus bupropion plus 2 short-acting NRT. That patient was in our residential treatment program. In admission, her serum cotinine concentration was 670 plus. And what we know about this is with a single-dose nicotine patch, a 21 milligram patch, the serum cotinine concentration at steady state will be around 150. So if you just take that as kind of a yardstick, then treating a person with a serum cotinine concentration while smoking of 670 with a single-dose patch would be underdosing them by a factor of 3. So that individual patient ended up on 3 patches plus a 14 milligram patch, and that's the most I've used in a single patient. The last question we'll be able to take is when will cytosine, the varenicline precursor, become available? Have you had experience with it? Cytosine is available in several European countries, but not available in the U.S. Except in herbal stores and where you can buy other naturally occurring substances. It's not been tested in the U.S. and I don't know when it will be. Dr. Robert West and colleagues from Eastern Europe published a study in the New England Journal of Medicine earlier this year, or maybe late last year, which shows cytosine had efficacy compared to placebo. So it is available in some parts of the world, but not so in the U.S. And I don't know that it's ever going to be completely tested here because there's not a pharmaceutical company that's going to sponsor that.
Thank you very much, Dr. Hurt, and thanks everyone for participating. Again, we will send you all a link tomorrow via email, and we will look forward to your participation at our next webinar.